And I just have to orient to the slides here. All right. I would like to start off this session by acknowledging that the Georgia and Fahey Center for Healthcare Innovation in Winnipeg is located on Treaty 1 land, which is the home of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. In coming together today, we respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past. We recognize the ongoing present-day colonial violence that is faced by Indigenous peoples within healthcare, education, justice, child welfare, and government systems. And we dedicate ourselves to moving forward in partnership in a spirit of reconciliation and collaboration. And when we talk about patient engagement, it's often Indigenous research that is at the forefront. And it's our belief that patient engagement and the activities related must be rooted in social justice and committed to achieving true systemic change and health equity. We're just having trouble with my slides here. There we go. In terms of conflicts of interest, I just need to disclose that I am employed by the Center for Healthcare Innovation. I have no other conflicts to disclose. Our intent is that by the end of this session, you will be able to describe important considerations when recruiting for engagement, identify key aspects of a successful recruitment strategy, and create your own one-pager for recruitment. Not necessarily a poster, but just a one-pager of info if you're looking for patient and public partners. And it's important, first of all, to start off to note that the term patient engagement may actually exclude the involvement of some people who may not identify as a patient for a variety of reasons. This includes people who are unable to access safe and appropriate care due to geography and/or systemic barriers. So that would be things like racism, colonialism, sexism, classism, ableism, heterosexism, just to name some. It also can exclude those living with mental health or substance use issues who may associate the label of patient with stigma or trauma. Those who refuse to engage or prematurely exit the healthcare system due to unresponsive or disrespectful care, and those living with a disability who are continually medicalized by the health system. And so language can really set the tone when you're recruiting for engagement. It's your first impression. It can have a huge impact on whether or not people choose to be involved. So first and foremost, one thing you want to do is make sure that the language you're using is accessible and easy to understand. We suggest aiming for a grade 5 reading level, using lay terms instead of medical jargon. So something like gum disease instead of periodontal disease, and avoiding acronyms wherever possible. And if you can't, just make sure you're going to define them really clearly first. Some suggestions from our team for choosing appropriate language include focusing on the person first instead of the health condition. For example, instead of homeless people, we would say people experiencing homelessness. Also, avoid making negative associations or assumptions. For example, just because someone is living with a disability doesn't mean they are suffering. So we'd say someone living with a disability. And often we ourselves use the term people with lived and living experience because people may be actively experiencing the issue or condition. Also consider how you're framing the engagement opportunity with respect to socially constructed categories such as gender. So for example, if you're seeking input around postpartum depression and you're not specifically looking for people who identify as heterosexual, cisgendered women, you want to avoid using words like mothers or women and instead be inclusive and say people who have experienced postpartum depression. And of course, this isn't always easy to navigate. We know that. It can be difficult to figure out on your own. And with most things related to engagement, it's always best to talk to people in communities with lived and living experience, or those who regularly provide services or resources in the communities you're looking to engage with, to make sure you're using the most appropriate language and framing opportunities in an appropriate and sensitive way. And this can be tough, especially if you're just getting started. We'll talk a bit more about who you can reach out to later in the talk. And if you can't, you can't. And either way, there's a good chance you're going to make a mistake somewhere or misstep. We're all human, we all make mistakes. We've definitely done it ourselves. What's important is that we own these mistakes. We accept when someone tells us that we're causing harm or that we've done something wrong and take responsibility for doing better in the future. Like I said, we have plenty of experience making mistakes ourselves, using the wrong language, and so we adjust and just do our best moving forward. But we want to emphasize, don't let the fear of making mistakes stop you from doing the work to engage meaningfully. And so what to think about when recruiting? We'll talk about what kind of factors and considerations should be taken into account when we're recruiting for an engagement strategy. First off, before you even get to recruitment, it's good for you to have a very clear idea of why you want to engage. And something we talked about in a previous session is that internal and external assessment of your readiness to engage. This involves critical reflexive practice, both independently and with your team, and with potential patient and public partners and communities, to gain a deeper understanding of your experiences, your values, beliefs, and biases, and how these influence ideas and methods of engaging in your work. It'll help you and your team to think about your own social location and that of the people or communities you're hoping to engage with, and how these relate to larger systems of power and oppression. Taking this first step can really help you and your team understand where there's room to potentially renegotiate power imbalances, figure out what decisions you're really willing to be flexible and adaptable around, and identify blind spots you might have in terms of needs or perspectives of the people you're planning to engage with. And once you've assessed your readiness to engage, you should have a better sense of what decisions you want to involve partners in making. You can then think about what specific goals or decisions you'd like to engage around. And this is always just an idea. Things may and often do change when you start to do the work. So flexibility and adaptability are key. That said, coming to the table with an idea of what you want to work on together can be very helpful. So you can think about what are your goals for engagement. Depending on what you determine in your readiness to engage assessment, your team may be open to input, more so on some of these than others. So do you want to engage with partners to look at priorities or develop the research question from the very start in the very early stages of the project? Are you looking to work together to decide on methods for recruitment and data collection, the language and content to include in study materials, making sure it's appropriate, sensitive, accurate? And can partners potentially identify some outcomes of interest? Are there opportunities for partners to be involved in actually conducting the study by recruiting participants or acting as co-researchers to collect data, maybe working together with the research team to analyze and interpret the findings, and even working on sharing the work with others? And once you're more clear about your goals for engagement, you can also think about the level of decision-making power your partners will be able to have. And it may be different for different components. For example, you may have partners driving decisions around the research question and what outcomes are important at that patient and public directed level, and then be more involved at the consultation level around research methods, with that decision being ultimately up to the research team. I won't go into any more detail about levels, except to say that knowing the level at which you plan to engage will help you communicate very clearly and honestly about the opportunity that you're looking to recruit for. And if you'd like to read more, there is a link to the blog on our levels of engagement, and we will share the slides with everyone who registered. It's a pretty content-heavy session, so I'll make sure that you have this all on hand later. Another aspect of engagement to consider when recruiting is the methods you hope to use for decision making, which again can vary depending on the stage of the project and the level of engagement, and may change once you start the work. They often do. Again, we won't go into detail on this, but you can find more info in our methods guide on our website, along with some other resources. And in developing a recruitment strategy, we really need to think about what factors influence people's decision to reach out and actually get involved in your work. What kind of things do we need to consider? What are motivations? Again, your best resource for this is always going to be people and communities with lived and living experience and the organizations that serve them. But the next couple of slides will hopefully provide some examples of potential barriers that should be addressed when recruiting. So we can think about the time and energy commitment we're asking of potential partners. Is it reasonable and appropriate? Does it match the level of decision-making that you want people to be involved in? Does it match your goals for engagement? How is the information presented in your recruitment callout? Is the language accessible and appropriate? And how are you framing the health condition or issue your work is engaging around? In terms of work and life responsibilities, what other commitments do potential partners have that may require you to be flexible or meet them where they're at or at different times? Some of them might work night shifts or they might be on call. Think about home and family commitments. How will you ensure people caring for young children, ill family members, or elders be considered in your recruitment strategy? What kind of scheduling conflicts are going to be likely? Usually we see staff having availability to engage during working hours, generally 9 to 5, Monday to Friday. That's when a lot of us work, but partners often also work full-time day jobs as well. And so will need to make time in the evenings or even on weekends to engage. And it totally depends on who you're hoping to engage with and how they generally schedule their days, obviously, but something definitely to consider. How will you ensure partners can attend engagement activities? If it's in person, do they need to use public transportation or do they need to pay for parking? Is the location safe and accessible at the times you're planning to engage, not just during the day? If you're considering engaging at a hospital or clinic, is this a comfortable and neutral space for partners, or would somewhere like a community center in their area they live be more appropriate? If you're engaging remotely, which most of us still are, do people have access to the technology needed, including internet services, data, calling, minutes? And do they have a safe and accessible space to engage in? Might they need to go to a local community center to actually be able to be involved? And a few more here. Why is your work interesting or engaging to people with lived and living experience? Why should they care? And why is their perspective important? What skills do they bring to the work? Is there a way to address power dynamics, particularly in the engagement methods you're planning to use? This is especially relevant if we think about relationships with power differentials like patient-doctor relationships, or when there are people involved in the project who are in positions of authority, especially like law enforcement or government. And are there plans to address safety, not just physical, but also emotional, spiritual, psychological, such as including supports like counselors or elders in engagement activities? What is the planned style of engagement? Are we relying mainly on traditional Western modes of discussion and decision-making, such as committees and voting? Is it inclusive? Are there other things we could consider? And what is the value being placed on non-empirical ways of knowing, such as experiential or Indigenous knowledge? So these are a lot, but just some of the factors to consider in developing a recruitment strategy, just some things to prompt those thoughts, and how you address them or don't will impact who chooses to be involved. And speaking of choosing to be involved, definitely something to consider is why people choose to get involved, and thinking about how the opportunity you're presenting meets these needs or desires. So we may look to get involved to help people who are living with a health issue, whether or not we're experiencing it ourselves. We might want to give back to our community and feel involved with those around us. Maybe we're looking to improve the quality of life or health services for ourselves if we're experiencing a health issue, or maybe it's for others, maybe our family members, other people in our community. And often we may not share this as a motivation. People may not think about this at the front of their mind when they're looking to engage, but it often is a benefit that comes along with engagement, especially in groups, is trust and mutual support from other patient and public partners, whether those are other people experiencing actual health condition, or maybe it's even caregivers, going through similar experiences. And having that ability to contribute to research and health services and be heard by that community and have a voice can be a big motivator. And now I'll go through, this is almost a bullet point list of the kind of things you'd want to include in a call for patient and public partners. So not all of this would necessarily go into a poster. That would probably be too much information, but if you're doing something like a one-pager you're going to share, this is the kind of info you're going to want to include. And so this is what we would ask for if somebody comes to, our patient and public engagement collaborative partnership saying, hey, we have this opportunity. Can you share it with your, your group and see if they're interested? This is what we would ask people to provide us with. First and foremost, your project information. Again, this is all wanting to be in lay language, not having acronyms, avoiding jargon. Your project title, which may contain those kind of things, but it's just so people can identify your opportunity clearly. An overview of what your project is about, and just not the engagement, the actual research project itself, right? And why you're doing it, and a description of the goals of this research or health services project, what the ultimate goal is. And then, of course, why this is relevant to potential patient and public partners who may want to get involved. And then more specifically, the engagement opportunity itself. So what are the goals of engaging patients, public, families, caregivers in this project? Are you hoping to identify outcomes, that kind of thing? What partners will be asked to do? So specific tasks that you might have in mind, attending advisory meetings, reviewing documents, those kind of things. How partners will be engaged. So specific activities if you're hoping to create an advisory group, if you want to bring on 1 or 2 patient partners as actual co-researchers. Again, this could change, but it's good to have an idea and be very clear about it in your opportunity call out. And which specific decisions partners are going to inform throughout the research, at least those that you're willing to share some of the decision-making power around. And then how partners' input will actually be used in decision-making. So that relates back to that level of engagement. Is this consultation and you'll take what they're inputting and consider it, or are they actually having some level of power in making that decision? And the roles and responsibilities, mainly what is expected of partners. So is there training provided? Do they need to have any research experience or any other experiences that are necessary? What kind of preparation they'll need to do for meetings or other engagement activities? What participation looks like, if there's a certain number of meetings, if there's key decision meetings that happen at a certain date and time that they need to be involved in, and how they'll need to report back if that's something you're looking for from the role. And then what is expected of the research project team? So what can they expect of you? Is there going to be regular communication, every month or every meeting? Somebody's going to come in and give an update. And how will you share updates on progress and decision-making, especially when there might be gaps in the research or health services project? This is a key one when you're sharing and people have to make a decision about whether or not they're even interested in being involved, is the time commitment and duration. When do you want them to start? And you can relate that to your overall project timeline. So maybe it's data collection or whatever it might be. The key time points for involvement. So if this is an ongoing multi-year project, what kind of time points are you looking at for actually bringing people in? Are they going to decide on outcomes and then you're going to go do data collection and then you'd like to come back and interpret with them, that kind of thing. The number of estimated hours per week or per month, depending on what your overall timelines look like. And this is obviously estimated. The expected duration of commitment. So how long is the project expected to go? And the last might be optional. I feel like you could even put in a sentence somewhere if you have room saying, this could change based on funding decisions, based on how the research project goes. It again, totally depends on the project and the context and who you're looking to involve. But it's good to give folks an idea of why these things might change, especially if you're expecting them to change. Letting people know in the call out whether you'll be compensating and or reimbursing them for costs, and being clear just with the audience here and in your call out that these are two different things, right? Compensation is paying people for their time, their energy, and their expertise, and letting them know how much they're going to get paid, how often and how they will be paid. So if it's gift cards, if there's different options for how they can be paid. This might not necessarily go into your call out, but you could say, we can discuss with patient partners how they want to be paid, that kind of thing. And then reimbursement, that's covering costs incurred as part of engagement. And the distinction is important because one counts as income and the other doesn't, right? And that can impact patient and public partners' individual financial situations. And so letting people know if you're going to cover things up front like childcare, if you're going to provide bus tickets, if you're going to provide meals, and then if partners are required to incur any costs, and if they'll be reimbursed for those. So those kind of logistical things, as much as you can ahead of time figure out, are good to share. And obviously, very important to include the contact information. When do you want people to let you know if they're interested by? What's the deadline? Sometimes we forget this, and the poster might be up or the ad might be out for months on end and we're still recruiting, but people don't know that because it's been there for a while. So that's good to include. And obviously who to contact, and give a couple different options, not just email, but also phone call. And obviously the name of the project or research lead, so they know who's leading this, and the name of the organization, which may end up helping you out in recruitment if it's one that's familiar with patient and public partners you're interested in recruiting. Okay, so that's kind of what you would want to put into, say, a one-pager. And so now we'll talk about some of the things we've seen in successful recruitment strategies and what that might look like. Thinking about ways of recruiting, and this keeps changing, especially with COVID, but we always, most of the time, it's word of mouth is the absolute best way to recruit. At least here in Manitoba. I'm not sure if it's the same elsewhere. But talking to local community healthcare or health consumer organizations, and this is all about relationship building, right? This part. So if you already have some kind of connection through your work or through your research with any of these organizations, in recruitment is a good time to try and, I guess, leverage those and see if they have any ideas about how to recruit, if they're willing to help you recruit, if they can think of people to recommend, that kind of thing. Healthcare professionals who may work with patients, families, caregivers who are experiencing the health condition that you're interested in working on. And people who are already involved in research. So researchers, parents, patients, and members of the public who can get the word out about what you're doing and how valuable it would be for other folks to get involved. Some other common ways of sharing opportunities that we use, direct messaging, emails, and e-newsletters. So that again goes back to those organizations might be able to share through those newsletters or through your own organization. Social media, either organically, so if you're already involved in, a Facebook group around pregnancy, for example, that might be a place to post an opportunity for engagement in research, or on Reddit in a certain subreddit related to whatever the health condition you're working on is, say endometriosis or something. And then there's also the option of paid ads, which I think we've looked at. Facebook is not, you can set a budget. It's quite easy and user-friendly. They want you to spend your money. So they make it easy for you to figure out how to share an ad through there. Presentations or info sessions. So this could be at different conferences, other places where people who you might be interested in recruiting already are attending. Obviously, physical advertisements, not so relevant right now, but things like posters and pamphlets. If we think about, if we're looking to recruit a little more broadly, as we have been in the past, we'll go to, local community organizations, and also things like gyms or like the YMCA, YWCA, drop-in centers, community centers, that kind of thing, where folks might stop and take a look. And then pamphlets you could have in a doctor's office or in a clinic, if you're allowed to at this time. And then information kiosks could be another one. Even we've had our collaborative partnership talk about setting something up in the mall. We unfortunately, due to COVID, haven't been able to realize that dream yet, but it's definitely an option for recruiting. especially if you had something like patient and public partners who are already involved, looking at being involved in being part of that. I see something in the chat. Oh, I'm just not going to worry about that. But if you do want to create, say, a poster or an online ad or something that's visually appealing and you want people to check it out at a quick glance, think about some of the design principles that are important in advertisement marketing. You want to be concise and straightforward. You want the relevant information there to be able to catch people's attention. Again, lay language, avoiding jargon and acronyms. Also think about accessibility considerations, things like high contrast, which means black text on a white background, and including alternative text if you have images. Also use lots of white space and have a call to action. And so I'm just going to go to the next slide, which has kind of an example of something we've used in the past. I probably would make a couple changes to this based on those design principles, but we've got a call to action right at the beginning. Join our collaborative partnership. This is what we're looking for new members to do. This gives you an idea of the commitment and tells you an honorarium is there, tells you what to do next to join us. It's got a lot of white space. It's not too cluttered. So this is, kind of an example of something that might be useful for recruitment. And we have posted this, things like YMCA, I said. But again, a lot of it's word of mouth. And so we can look to our partners, people to help us recruit. And because word of mouth is so popular, this is really can be crucial to your recruitment strategy. Again, healthcare consumer organizations, something like Heart and Stroke Foundation or Arthritis Foundation. Local community organizations, as I mentioned, local leaders. So that might be folks who run those organizations, if you have those kind of connections, local politicians, even healthcare professionals who work with patients in the public experiencing the health condition, health researchers who may be able to connect you with some of those above bullet points, or may know where to get you started, or may actually have connections themselves. And research institutions, one of ours here in Manitoba actually has a webpage dedicated to research opportunities. So looking at the institutions that you work within and work closely with, maybe your collaborators work with them, seeing if they have avenues to share opportunities that are often seen by patients, the public, or caregivers. Other engagement professionals, again, networking with those in your local area or even across Canada to talk about things like these, kind of like we're doing now, right? And share our ideas. And always patient and public partners. A lot of our recruitment has been through people saying, hey, this was a great opportunity. I enjoyed working with these people. I like what they're doing. I think you should check it out. And that's, like I said, word of mouth has been a lot of it. Okay, and so once how have other researchers selected patient partners if more? That is exactly what we're getting into, Saint. That's funny you should ask that. So yeah, the next step is, okay, let's say you've got tons of people responding. Now what do you do? So first, I added in this slide earlier this morning because I thought, okay, there's different ways for people to get a hold of you, right? So these just some different options for how you might want people to, say, apply or respond to your call out. So, you could have something as basic as calling me on the phone. Here's my phone number. If you're interested, give me a call, we'll chat. Maybe it's an in-person chat, in better times. It could be email correspondence back and forth, or you could even have something a little more formal, like an online form. So you're gathering a standardized set of info so you can kind of compare who's responded and what they've said. Some of the kind of things you want to look for in that, I guess, early application stage, just the basic information, their name, the best way and time to contact them, what their availability is like, where they can travel to, or if they can't travel, if they have to do, video conferencing only, if they're available to come in person, any other accessibility needs or accommodations they might have, things like translation, Audiovisual aids, lighting, we've had people who require chairs without wheels due to vestibular conditions, quiet atmosphere, that kind of thing. We've also included in one of our applications form, which we got feedback that this was a helpful way to ask about skills and abilities, was have a checklist. So thinking about the kind of skills and abilities that might be needed to be involved as a patient and public partner, include those. So maybe it's experience caring for someone living with this condition. Maybe it's experience speaking publicly, experience, in Microsoft Word or whatever it might be. And then getting an idea about what makes them want to get involved and what they hope to get out of being involved. So you kind of get an idea of what their motivations are for actually reaching out to you. So that's kind of the application stage. And then once you've found some folks that seem like they're interested and they're a good fit, the availability works and, they're interested in your specific project, you might want to actually have, I say meeting, it could be kind of like an interview, but it doesn't necessarily have to be super formal. We try not to make it as formal or make it as informal as possible. For that though, one recommendation we've had is making sure you're providing the format. So how are they expected to show up? How long is it going to be? Who's going to be there? What questions are you going to ask, or what are you going to talk about? So they have a little bit of chance of prepare for it. We like to involve any existing patient and public partners if possible. This helps both with making the environment more comfortable, addressing some power differentials that might exist, but also giving us a chance to see a different perspective. So our patient and public partners, what do you think of this person? Do you think they should be part of this? And do you have any questions for them, or do you have anything that they should know about this opportunity that you think we might have missed? And remembering that it's a two-way conversation. Not only are you seeing if they're interested and they're the right fit, but they have to also make sure that you're the right fit for them and that this project is what they're looking for. And it'll help to do that by discussing expectations and needs, both yours and theirs, for this opportunity to make sure that they can be met on both sides. Getting a feel for supports that might be needed that might not have already been identified. So if someone's kind of shy, maybe not really talking, but they give you a really great application on paper, maybe considering that you may need to have an option in your engagement methods for people to respond non-verbally. And you can get a little bit of a better idea for the reasons for wanting to be engaged and learn more about their experiences in research or health services or whatever they might want to share, and give a little bit more info about your experience in research and maybe engaging with patients and the public. So getting to know each other basically and starting that relationship. And so we thought we would include here some of the things that, how do I know if a person should not be included in my engagement strategy, should not be included in this opportunity with other patient partners? Some things we would say are definite red flags. If they're unwilling to listen to others' perspectives, if they're not interested, if they're there, they want to have a voice, they want to be heard, but they're not willing to listen. That can be a major issue, especially if you're working in a group setting with other patient and public partners. If they're blatantly and unapologetically discriminatory against certain groups of people, that's just not acceptable. That can't be tolerated in a safe and inclusive environment. If they have an obvious lack of respect for physical or emotional boundaries, crying is for blanks, or those kind of attitudes that they're not willing to change, that can, create an unsafe space for other patient and public partners or even members of the research team. And if they discount the need for safe spaces, if they don't think that's a thing, it's going to be really difficult to create a safe space if somebody's not willing to work with you, right? And if there's a total misunderstanding of the opportunity, and this isn't necessarily a red flag on the part of the person you're interviewing or meeting with. It could be that you've totally missed the mark on explaining what this opportunity is about. So maybe you need to take a step back and look at, are you being clear enough about what this opportunity is, especially if it happens more than once. Some things, however, that are not red flags include if somebody has a totally different opinion from your own, even if it's something like the value of science, it doesn't necessarily mean it's a red flag, right? A lot of what we're looking for in patient and public engagement is perspectives that are very different from our own and being inclusive of various perspectives. So that might be someone who challenges you. They may openly disagree with your perspective. And this is, unless they're making you actually unsafe or they're creating an unsafe environment, it may just be uncomfortable. It may not be unsafe. It may just be being challenged about your perspectives, your views on the topic, and biases you might have. If you're being called racist, that's not necessarily making an unsafe atmosphere. It may be that a conversation needs to be had. Maybe we need to back up and look at, why is this person saying that? What am I doing? That kind of thing. So not necessarily a red flag though. If they value different ways of knowing, so if they're prioritizing experiential knowledge about their own body, if they're, say the study is related to pain, and we're talking about, biomedical pain receptors, and they're talking about metaphysical, right? That doesn't necessarily mean that's a red flag. Same thing with religious or spiritual beliefs. Mistrust for authority, those are going to be voices that are often not heard in traditional health research settings. And so those could be really valuable insights and help us have a really transformative experience with engagement if we're including, if somebody who's totally mistrusting authority is willing to work, with a physician in a research project, that can be hugely transformative for both people. And introversion or preference for nonverbal communication. Just because somebody may not be willing to speak up in a group, it does not necessarily mean that that's a red flag or that you shouldn't include them. And again, that's often a voice that is going to be missing from traditional opportunities that prioritize the vocal, the strong-willed, and those kind of folks. So not red flags. Okay, and I've done a lot of talking, so I'd like to just wrap up with a few, I guess, tips for success when recruiting and thinking about recruitment and starting to build relationships with partners. It's all about relationship building. It's all about working on building that trust, being clear, but also being flexible. So having a very good idea of where you want to go, but being willing to take a different route to get there. Being patient, knowing that it takes time, not only to recruit, but to get things done when you're engaging. And that in the end, if you're really committed to this meaningful, safe, inclusive engagement, it will be worth it. Meeting people where they're at, being open to working with different personalities and viewpoints. Again, it all comes down to adaptability and flexibility, which we think are some of the major keys to meaningful engagement. All right, I have done a ton of talking. So I'll open it up to any questions. You can go ahead and raise your hand. You know what, at this point, I'm actually going to allow people to unmute themselves. I'm just going to lock the meeting here.
Thanks so much, Trish. You brought up some really great points. I love it. And I'd love to hear, if there's any questions in the chat box, or you can raise your hand.
I know it was a ton of information. Yeah, so I don't know if I directly answered Saint's question about selecting patient partners if more respond than are needed. We have gotten that before in recruitment. And so often we'll try and connect folks with other researchers doing similar work, or if we know of other engagement opportunities. That's why it's really good to network with other people working in engagement or working on similar research projects, or other people doing engagement in your area. Or letting folks just be honest and let them know, we've reached our quota. Is it okay if, we keep you in mind in case something else opens up? And it might just be, It depends, are you just looking for a certain number of people? If you are looking for certain demographics, if you're trying to include voices that are often not heard, it's okay to say that. We've definitely put out calls ourselves that says, we're missing the voice of Indigenous youth in this group, and that's specifically who we're looking for. Anything to add on that one, Carolyn?
Yeah, I think everything you've just said works well. Well, when you're talking about different prospective partners, and I know we've even had times where we've done some recruitment for one committee, and we met so many amazing people. We were like, oh my goodness, that we were able to find other opportunities for the ones that weren't able to necessarily. We had too many people for a committee, so kind of keeping an eye out for other opportunities, keeping that connection with them, letting them know, unfortunately, this didn't work out, but can we send you an opportunity? Can we connect with you if something else comes up that might be more of a fit for you?
For sure. Just looking, do you have any raised hands? Either I did a really good job of conveying that information, or it was just a lot for people to process at once. I don't see any questions or hands. You did a great job. Okay, that's good to hear. Maybe I will, I think what I'll do is toss in one little other slide that I wasn't sure whether or not we were going to talk about.
Yeah.
Let me just share my screen again here. And so I thought maybe we might get a question about, do we need to get ethics for this? Because we get that question all the time. And so we adapted this flow chart based on a paper by Doria et al. Looking at discussion versus focus groups. The first of which are more for making decisions, the second of which are more for collecting data. And we adapted it to help folks figure out, do I need to get ethics for this project? Maybe they want to recruit people to design a survey, but they also might want people to be involved in that survey. So it can be a blurry line sometimes as whether or not you need ethics. So we created this flow chart. It should be helpful. It won't apply in all situations. But basically the major question is, are you collecting data about patients? And by collecting data, we mean, are you collecting information that you will be reporting on publicly? Are you going to be sharing this information at all? Or are they just, they're almost as co-researchers, right? Are they just there to inform and you won't be reporting on who they were or what they did or what they said, but they're part of the research team. So that's kind of I think the tipping point for whether or not to seek out ethics. But if you're not collecting data, you may end up wanting to quote patient partners, and going back, obtaining informed consent may be sufficient. But all this to say, things are changing, at least here in Manitoba, with the way ethics are being processed for research. So it's always a good idea. And we always recommend just to talk to your institution's ethics board, even via email, to say, hey, this is what we're planning on doing. Is this something we need ethics for? And then if they say no, you have that, on record. And if you're at all ever planning to report on engagement process itself, or include any of that data, it's never a bad idea to go through the ethics process. It'll also help you think about the different components of your engagement strategy, and are those ethical, and how those are being done, and how those can be consented for, and that kind of thing. So it might be actually helpful to work out the details, but all that to say, check with your ethics board.
We have a question from, first of all, you're getting tons of love. So Carrie says, great job. And Emily as well. And well done from Jeanette. Bev is asking, speaking of ethics, I wonder what your thoughts are on ethical behavior or accountability on the front end for patient partners. How do we ensure people are not being harmed? And if they are, who's responsible for that? Maybe this is a different webinar.
I think that kind of speaks to the, and we've talked about this too, is, you know, if you think about who's involved in research, often researchers have, you know, their faculty association or the university itself. If something is happening that's not ethical, or if something goes wrong, they have somewhere to turn. Students, you know, have, oh, I can't remember what it would be called, but they have somewhere to turn, right? They have somewhere to turn if something is going wrong with their relationship with their supervisor, something is being done that's not ethical or that's harmful. And we think about patient partners, really, right? Like, where do they have to go to address those kind of issues? And so often I think it falls on the shoulders of patient engagement practitioners like ourselves to kind of manage those. If there's relationship breakdown, if there is unethical practices happening, you know, sometimes we have to advocate on behalf of patient and public partners when there might not be anyone else to do so. I see Carrie's mentioning Child Bright has a webinar about engaging youth in ethics issues, but few answers right now. Yeah, that sounds about right.
That's, yeah. And I think I would agree with Trish, having those conversations about rights and responsibilities for people with lived experience as well. What are their rights? Like that you can at any point in time leave, those types of things are really important. I know we do some talks sometimes on trauma-informed engagement, where we build guiding principles together around safe and inclusive spaces, and that gives kind of a shared language for anyone in the group to be able to signal to people that they're feeling that giving that common language to say, hey, can we go look at the guiding principles again, to bring that up, bring up times where they may feel that there has been some violation of safety in that space as well.
But yeah, I agree with Carrie, definitely. I think the next step is that accountability piece.
Yeah.
Okay. Well, we're getting near enough to the end of this session, so I think I'm going to wrap it up there. Thank you all for joining us. I would like to promote our next session. It's on Tuesday, December 14th from 12 to 1 p.m. Central Time, and will be presented by Sarah Kirby. She's our lead for health quality and patient-reported measures here at CHI. And she's going to discuss patient-reported measures, what they are, and the engagement of patient and public partners in developing Manitoba's patient-reported measurement strategy, and how they're embedded into the strategy itself. So I will send everyone who registered a link to an evaluation for this session, the recording and the slides, and a link to register for the next session. So thank you all very much for joining us, and we'll see you next time. Okay. I have to figure out how to end the meeting. There we go. Okay, bye now.